security, protecting the people of Africa. And I will immediately pass the floor to our moderator, Ms. Julie Gichuri, who is the founder and CEO of Arimas Media Kenya, and most of you know her as the host of the TV show Africa Leadership Dialogues. Julie, over to you, please.
Good afternoon, ladies and gentlemen. I hope you enjoyed your lunch and the lunchtime session as well. Are you ready for our session on global health security, protecting the people of Africa? Are we all ready? Thank you so much. We are also tweeting, so I hope in this room you are sharing information with millions of others who can be incorporated into the conversation. That's absolutely critical. Now, every year, let me share some statistics. Every year, the World Health Organization Africa region is challenged by over 100 outbreaks and health emergencies. What does this mean? This means unacceptable deaths and disability. But this is also a socio-economic burden for communities, for countries, and for the continent. It's a political challenge, and it is a security challenge. And finally, we are recognizing that this is important. We are here today to look at how we tackle outbreaks and other health emergencies, how we confront the challenge facing us. There is a need that we recognize to advocate for strategic positioning of public health emergencies as a global health security issue. But what must we do? In this session, we're hoping to look at the lessons that we have learned so far. That is critical. We want to highlight the challenges that we face. We want to look at feasible options on the way forward, solutions. What are they? And importantly, what resources can we leverage to address the challenges that we face? In this session, we have an incredible panel, and I'm going to introduce them now. Dr. Donald Brown, Director, Eastern Central Africa, DFID UK, thank you so much for being with us. Dr. John Kengasong, Director, Africa CDC, based in Addis Ababa, Ethiopia. We have Dr. Rebecca Martin, who is Director of the Center for Global Health, based in Clifton, USA. Dr. Adeiza Ben Adinoyi, Head of IFRC Africa Health and Care Unit. That's the International Foundation of Red Cross and Red Crescent Society, Federation of Red Cross and Red Crescent Societies. And we also have with us Brigadier General Dr. Emmanuel Ndahiro, who is Commandant and Director General of the Rwanda Military Hospital here in Kigali, Rwanda. Do I call you Doctor? Commandant? Brigadier General? Doctor is okay? Doctor is okay. Thank you very much. But first and foremost, ladies and gentlemen, can we give a very warm welcome to the lady who is giving the keynote address this afternoon, Honorable Dr. Bernice Dan, who is the Minister of Health for Liberia. Thank you very much.
Honorable Ministers, distinguished ladies and gentlemen, good afternoon. I just want to start by thanking the organizers for this forum and for the invitation, and to also say that during our time in providing healthcare, I don't think there's any bigger experience and lessons learned than what we learned from Ebola during our time. And so, distinguished ladies and gentlemen, Liberia was unprepared when Ebola struck. When the Ebola struck in 2014, it encountered a health system recovering from the adverse impact of 15 years of crisis, civil crisis. The proportion of the national budget spent on health had increased steadily from 6.8% in financial year 2005-2006 to 11.5% in financial year 2013-2014. The Liberia Demographic and Health Survey conducted in 2013 had demonstrated significant increase in coverage of key interventions, including childhood immunization, ITN ownership, IPT2 coverage, and an impressive decline in infant mortality rate. In fact, Liberia was indeed one of 8 sub-Saharan African countries that had attained MDG 4 3 years before they ended. These modest gains notwithstanding, the Ebola virus was able to take advantage of the underlying weaknesses in the health system, some of which include weak disease surveillance capacity. At the time Ebola struck, there were only 2 staff at the Ministry of Health fully assigned to supporting disease surveillance. Lack of laboratory capacity. It took 10 days from report of the first EVD suspect case to receive laboratory confirmation results from a laboratory in neighboring Guinea. Health workers not familiar with EVD had very poor knowledge of infection prevention and control. This, together with poor public health infrastructure, quickly resulted in health facilities becoming areas for amplification of virus transmission. Community distrust of health service providers and poorly designed health education messages led to an initial negative community response and persistent unsafe practices. Spread of the virus over a wide geographical area, including in densely populated areas of Monrovia, quickly overwhelmed the limited outbreak response capacity that existed at the time. Liberia's core capacities to detect, assess, notify, report, and mount prompt response to public health events and emergencies were very minimal in 2014. This situation was further aggravated by the long delay in arrival of international support to boost our efforts. The Ebola virus entered densely populated areas in Monrovia in late June. The first significant numbers of international response teams began arriving late August, early September 2014. What are some of the important lessons learned during the response to EVD outbreak? Despite the difficult start, the Liberia team, together with the international responders, worked very hard to improve the quality and effectiveness of the EVD outbreak response efforts. The deployment of experienced responders resulted in a more meticulous application of the traditional EVD response strategies, including contact tracing, surveillance, case management, safe burials, social mobilization, infection prevention and control, laboratory, and logistics support. In addition, innovative strategies such as community care centers, the rapid isolation and treatment of Ebola were introduced to address the monumental scale of the outbreak. Important lessons learned were learned during the outbreak response phase. 1, strong national leadership and whole government response was critical. The government of Liberia chaired the National Incident Management System that brought together all relevant ministries and agencies, including all the national security institutions. The incident manager reported on a daily basis to Her Excellency Madam President, who chaired a presidential advisory committee on Ebola PACE. 2, very strong and functional coordination mechanisms at the national and subnational levels improved the quality of strategy implementation. The IMS brought together government agencies, partner agencies, including the UN, bilateral agencies, NGOs, international response team, foreign medical teams, including US, Cuba, Germany, China, professional associations, and civil society groups involved in the response. During the daily IMS meetings, teams involved in surveillance, case management, IPC, social mobilization provided daily updates. Joint decisions were made, assignments given, and the respective teams held accountable for results. Similar structures were established in each of the 15 counties. The cluster system was also put in place, with clusters co-chaired by Government of Liberia and UN agencies. 3, implementation of innovative and effective community engagement strategies that took into account appropriate community initiatives, resources, and knowledge contributed to the successful interruption of transmission. Implementation of capacity building activities to ensure that experienced international responders transfers key knowledge and skill health system in Liberia. Implementation of this plan, which began in May 2015, is being funded using our national resources and international funding, including balanced funds that had initially been provided for EVD outbreak response. The investment plan aimed to address the main gaps that had been demonstrated in the performance of the health system, particularly in the areas of health workforce, health infrastructure, epidemic preparedness and response, that is the IHR core capacities, as well as quality of health service delivery, amongst others. The investment plan for a resilient health system also aimed to ensure that the important contribution of the community to the outbreak response were made more systematic in the efforts to build a more resilient health system in Liberia. Several achievements have been registered over the last 2 years in the implementation of the investment plan for building a resilient healthcare delivery system. These include: 1, the establishment of the National Public Health Institute of Liberia, that includes a public health capacity building center as well as emergency operations center as core structures for stewardship and implementation of the IHR 2005. 2, nationwide implementation of integrated disease surveillance and response strategy through the deployment of 1 dedicated surveillance officer in each of the 91 health districts in the country. All these efforts have undergone basic training. Officers have undergone basic training in field epidemiology and are equipped with transport and communication. All 15 counties have developed county epidemic preparedness and response plans and have trained multidisciplinary rapid response teams. Since 2016, all counties' rapid response teams implement annual simulation exercises to test capacity for prompt detection, investigation, and response to viral hemorrhagic fever outbreak. 4, establish National Public Health Laboratory Network with capacity to test at least 7 of the 9 priority IDS-RO diseases in Liberia. 6, in 2016, a total of 38 outbreaks were reported, with 20, which is about 52%, having a written outbreak investigation and response report in line with the national IDS-RO guidelines. Liberia volunteered to have a joint external evaluation of the IHR core capacities in September 2016. This confirmed progress made in the end of the EVD outbreak, with demonstrated sustained capacity in immunization, real-time surveillance, emergency response operations, and medical countermeasures. A new quality management unit of the Ministry of Health has been institutionalized and is monitoring infection prevention and control. A national community health assistance program launched in July 26. There are now trained and paid community health workers who are a formal component of the national health delivery system. Liberia continues to experience a number of challenges. The joint external evaluation pointed out slow progress in terms of implementing the One Health concept, as well as very minimal capacities in antimicrobial resistance, laboratory quality system, points of entry, chemical events, and radiation emergencies. Lack of predictable multi-year funding to sustain the gains made, including cost of addressing the gaps identified during the JEE, as well as the cost of the new community health assistance programs. Gaps in quality of health service, including occasional drug stockouts, shortage of trained health workers in hard-to-reach areas. Poor capacity of regulatory authorities to sanction health facilities, particularly the private for-profit that do not comply with national IPC standards. There are opportunities for Africa. We have benefited immensely from strong partnership at county level, at sub-regional and global level. We are very grateful to our partners for the great support they extended, not only to Liberia, but to all countries, agencies of the...
To wind up. The Minister, we're suffering from either misappropriation or misuse of funds in certain environments. There is a lot to be done. Going by what we've heard from the Minister, this is a task ahead of all our governments. Your perspective as a donor over the years, we do want you...
Session I will try and... I would slightly disagree with that, a lot less this morning. But actually, what the onus is demonstrating that money is used well. And that's the responsibility of the government. And we need to ensure that money is used well and convince ministers of finance and governments that the three E's are there, that this is effective, this is an economy, and it's efficient use of resources. You start doing that, and I think we get somewhere. I think the other issue, which we heard this morning, is about transparency and accountability, which is also very much in here. I hear lots of debates about, when, for example, acute watery diarrhea is cholera, and when it's not cholera. Very often it's cholera. We need to call it cholera, and we need to therefore respond to it. So it's about that transparency and accountability, and then you can have an appropriate response. Until we have more transparency and accountability, and then going to your other point, I've seen, for example, around Ebola, in the response, ambulances used as personal vehicles, not as ambulances. Right. This is all about the effective use of resources. So we need to have that in there, doing the basics well. We need to, I've got about 2 or 3 more points. We need to take an approach that's based on risk. So where are the biggest risks? Both at country level, continental level, but also at global level, and then invest in prevention around those risks. Very often we tend to put money into countries that already have a capacity, rather than countries, and this is a donor, rather than countries which don't have a capacity. Because often the countries that don't have a capacity are the more difficult ones to work in, are the ones that actually have the problems.
And the ones in most need, which
exactly.
raises questions about the
But then we have to have a more honest conversation about what we need to see as investors in those prevention systems and the responsibilities of government. And then I think
and that's results-based?
And that has to be results-based.
Okay.
And I think the 2 last things are about partnerships.
Very quickly.
Too often we think that
people are the center of IFRC's response, people and communities. How do I characterize this? Across Africa, we have 1.8 million volunteers in 49 countries across 2,700 branches, which are linked to the districts they work. These enormous human resources as characterize solutions as disease challenges, which for us as at International Federation of Red Cross is a drift we're having, moving away from characterizing solutions along disease burdens to a holistic approach to addressing human suffering and vulnerabilities. You see, so that is the basis of our resilience framework. So we don't just do public health interventions. We do this in combination with other interventions that address vulnerabilities like livelihood promotion, disaster risk reduction, food security interventions. So in doing this, we put the community at the center of addressing these challenges. How do we put communities at the center? We don't go with solutions that we have formulated or created. We join the community in finding the solutions through community engagement, which the minister had mentioned earlier. And in our side, we don't just refer it to community engagement. We say it's community engagement and accountability. So what it means is that we are joining the communities to find solutions to their problems. We are joining the communities to discover new solutions to the problems that existed within the community. The communities, they know these problems. They know the solutions. But it's the articulation of these solutions to address the problem that is the challenge. So we support the community in framing the solutions and in putting the solutions to work through community engagement. And we make ourselves accountable at the end of the day to hearing back from the community if the solutions are working, if we are addressing this in the appropriate way. Then the next point is that we also ensure that community own these solutions. Mm-hmm. And not just owning the solutions, you cannot own anything if you are not empowered. So first and foremost is to ensure that there is investment in social, physical, and human capital to enable the community to take ownership of these solutions. Mm-hmm. Then lastly, we ensure that communities are connected to institutions and structures that are either designed or put in place by the government or other civil institutions. And even where these do not exist, we support communities to create systems or structures within their communities, like we have the Mothers Club, we have the Youth Club, we have the Grannies Club. We have all forms of structures that can be created at community level to support solutions that have been provided to that have been discovered within their communities. So these are the few ways we try to support communities to address health challenges, to address public health challenges, or other forms of vulnerabilities.
It's so simple, it makes absolute sense. But sometimes you just have to go back to the basics, don't you? And coming from that, I will come back to you, Ben, on multi-stakeholder engagement. So you've told us how you work with the communities. How do you work with government? And who are some of the other partners that are critical? I'll come back to you on that in a moment. But Dr. John, I want to come to you first and just ask the question. We've seen how quickly outbreaks can spread across borders, the panic it causes, the struggles that we then have. How do we ensure that measures that are recommended to mitigate cross-border spread of diseases are effectively implemented? How do we get those partnerships working? Who are the key stakeholders there, please?
Thank you for the opportunity to be part of this panel. I think the fundamentals of our discussion is how do we strengthen our health systems. And I'm really delighted that the minister took, in her presentation, actually touch on that and how Liberia took advantage of the crisis to strengthen its system, especially the concept of the National Public Health Institute, which I believe is foundational to our ability for each country to respond to any outbreaks. Now, you can't prevent outbreaks from occurring. They will occur. We can't prevent outbreaks from crossing borders. They will cross borders. I think the key and fundamental question is how do we harness the resources that we have, what are characterized as the public health assets that we have in each of the regions, and bring that to bear to respond to each outbreak. My sincere belief is that we have to be realistic and say that the concept of partnership and multi-sectoral approach to address these outbreaks is no longer a strategic goal. It's no longer your choice. It's a must. We must build the right partnerships across borders and develop networks, regional networks that feed into a continental networks that can actually properly respond to these outbreaks, because they will definitely occur. Now, as we approach system strengthening, I think to be more responsive to the topic of this panel, which is global health security, we still need to have a dialogue around when we refer to strengthening systems for global health security. Are we referring to resilient systems that will support non-communicable diseases? Are we referring to resilient systems that will support vertical diseases there. So we have to have that dialogue that brings all of this together. So that way we do not have silos of systems that we prepare them for specific needs and then neglect other aspects there. Thanks.
Do you feel the dialogue is happening? Is Africa being proactive enough about having that dialogue?
Yeah, I think dialogue is happening. When I listen to the Minister of Health from Liberia, I'm very encouraged that the approach they used in Liberia wasn't siloed. I think that I'm hoping that the approach will enable them by strengthening the existing systems to be able to respond to whatever outcomes there are, be it non-communicable diseases, outbreaks, or vertical diseases, because they all. My thing is this: to be able to prepare for the unknowns, we have to prepare adequately for the knowns. The knowns are the things that we're dealing with today, which is HIV, right, tuberculosis, malaria. If we practice in peace times and use our systems to respond to those, then I think we are getting ourselves closer to being prepared for the unknowns.
So similar to what we had from Dr. Donald, which is get the basics right anyway.
Exactly.
So let's do what we need to do what we know, what we can predict, what we see, let's get that right so that we can deal with the unpredictable. Rebecca Martin, Dr. Rebecca, let me come to you now. And the US, in collaboration with other partner countries, has invested in the global health security agenda. Tell us, how does this contribute to protecting the people of Africa against health security risks?
Well, first of all, thank you again to be on this esteemed panel to have this discussion today. The Global Health Security...
Please move the mic a little bit closer.
Okay.
Thank you.
The Global Health Security Agenda was actually launched before the Ebola outbreaks in West Africa were first detected, and it took very little notice across the world. It came in very quietly, and there was not much notice to this. But what it really was to do was to accelerate countries' ability to meet IHR, the International Health Regulation, core capacities, and to do that quickly so that countries could be prepared, they could detect, they could prevent, and they could respond rapidly. To date, it's over 58 countries that are members of the Global Health Security Agenda, including the United States government and international organizations, private sector you've heard as well, non-governmental organizations are all part of this. And the main effort here is really, as the Minister of Health from Liberia mentioned, is starting with what's called the Joint External Evaluation, which is an assessment to see where the gaps are in a country's ability to prevent, detect, and respond. And from that, to then develop a national action plan that's then costed, implemented, and then assessed again. And all of this has to be country-led. It has to be country-led, country-owned, and country-implemented. And this is so key for these efforts. And I wanted to give two examples. First of all, in Ghana, the work that's being done in the second year of life to catch up children who have not been vaccinated by the age of 9 months. And they're going up to 18 months. But it's including the efforts at a community level, which you've heard about the importance of engaging the community to be able to conduct surveillance, to know what's occurring, the ability to integrate, to work with the school systems as well, to find those children who may not have been vaccinated, and then with the healthcare facilities. So it requires the integration, the multi-sector, and multiple partners for this effort. In Cameroon, the other example I want to give is their effort to respond to highly pathogenic avian influenza, H5N1. And in a matter of 24 hours, when it used to take them up to months to stand up their emergency management system, they have been able to quickly come together as multi-sector, Ministry of Health, Ministry of Forestry and Wildlife, Ministry of Agriculture and Animal Health, coming together with partners in that command control setting to be able, under the leadership of the government of Cameroon, to respond rapidly, to prevent and to stop outbreaks from occurring. So these are two strong examples of what we're seeing by country ownership and country leadership of really making changes in the system by identifying where the gaps are and addressing those, not only as Ministry of Health, but Ministry of Finance, the multi-sectoral, and the partners at all the levels, from community to global.
Thank you for that. And I'm going to come back to multi-stakeholder engagement, because that's getting that done is a challenge in itself. So we're going to talk about that. Doctor, I come to you now, and strategically come to you after everybody has spoken, because you have rich experience in defense and intelligence, you're a doctor yourself. So, I want to understand from your perspective, your honest contribution as to the role that national government plays, the lessons that they need to take on, the new practices perhaps that they should adopt to make sure that we're not practicing business as usual and that we are really giving to our communities what they need, which is healthcare systems that work, please.
Thank you very much, Judy. I notice there are many experts in the room. I suppose matters of structure, processes are already taken care of. But my experience has largely been about innovation. Innovation through a discourse that involves multidisciplinary, as everybody else is saying. Through that process, you own whatever it is. In this sector, for example, I have only been here for 1 year and a few months, not very conversant with many. I've forgotten a number of definitions. But I find effective leadership in terms of putting people together, being decisive. Decision-making is a very critical thing. When do we decide? How do we decide? When I spoke about processes, a decision arises out of processes, and therefore the structures matter. The experience I have is, even currently, I don't want to go back into history. I have access. Here I'm representing the Minister of Defense, and I'm just Director General in the hospital. The ease with which we can assemble on any given issue and the ability to agree. So leadership is critical in developing a consensus. So we define the agenda and the structures. We found the structures here. They exist. We improve efficiencies. The issue of resources is a problem here as it is even in the developed world. I haven't found anybody who doesn't complain of not enough resources. The examples, I'll give examples of across board. I'm not going to speak exclusively of the Minister of Health. Let me begin with the Minister of Health. The structure I was referring to. There is what they call Abajyanama b'ubuzima, community health workers. The effective and timely response at the grassroots level. They establish a mode of communication, and the decision is made in a very short time because it goes directly to the principals in the Ministry of Health. So we involve communities in everything we do. How do we innovate? The other example of innovation. Health services are very expensive. Very, very expensive. And in a setup like ours, we have people who wouldn't have access to health services. The example of Mutual, the community-based health insurance, how people came up with these decisions. One of the structures I find very interesting is the government structures and decision-making. I'm still talking about structures and decision-making. The government holds a retreat every year, once in a year. You would have expected decisions to be made in different environments, but decisions are made in this assembly that involves almost everybody, legislators, the judiciary, all institutions of state are in the room. And the consensus necessary is developed, but it involves even the local communities. We have the mayors, the executives at the local level. So involving the communities, I will talk about innovation as an incentive for the military to stick to what they should do and provide a sincere, accountable systems. For many people talked about this funding.
Now, our capacity to deal with crisis of this kind, who are the stakeholders that you need better engagement with, and what would you challenge them to do?
Thank you. I think we are all stakeholders. Paused and came up with an idea of a paradigm shift in how we address the collective threats that face us in communities. And this was when the 1 billion coalition, as we call it together, was given birth to. And the idea of this is that we should bring our collective resources in the response and preparedness at crisis and
critical partner in this, as well as we've heard, is all the different stakeholders. Technologies, either be it vaccines, diagnostics, the opportunities to do innovations quickly, and the ability also then for them to be able to look at innovations in a way not
governments on the need
circumstances in the plus we are beneficiaries. One time, for example, malaria is a serious issue. You know, the chief of defense staff calls and says half of my company on the border is sick with malaria. So we have stakes even at the level of security in the interest of ourselves. We have also been involved, we are championing, or we are part of a process that is discussing innovation through research. Malaria is still here when the rest of the world has been eradicated. It's not a priority there. So who is going to find a solution on malaria? Those are I have the skills in the hospital. You look at the numbers. You look at the access. You are taking the health care to the people in their villages. You look at the issues of awareness, ownership. We have been largely doing that. We benefit from the fact that we are all over the country. As I say, the resources.
More than ever, I sense a willingness even for ministries to work together. Now more than ever, you're seeing finance ministers taking a seat to discuss. Funded.
But I think we also have a duty as these things move forward, funding.
Kenya Airways and other airline carriers know the impact, for instance, of Ebola on their businesses. And gentlemen behind you, and then.
My name is Robert Kwame Ejako. I'm the lead advisor for outbreaks and epidemics for the African Risk Capacity. We have heard a lot about the challenges faced by African countries in the event of outbreaks.
In the last few
to gentlemen right at the back, and then we'll come to this end. Thank you. Yes, go ahead, please. Sierra Leone has the floor. Thank you. Can we get a mic at the front? It seems to be posing a challenge. Thank you. Thank you very much.
Thank you very much. I'm Mrs. Cooper, Deputy Minister of Health from Sierra Leone. And I'm looking at the topic we actually are supposed to be discussing, lessons learned. What I haven't had, I'm sorry, I'm going to deviate a little bit, which I normally do. What I haven't had is the miscommunication from the onset, from Guinea, Liberia, and Sierra Leone.
Right.
And that greatly affected the security systems. The first message, the initial message was that there is no cure for Ebola. And once you catch this dreadful disease, that is it, which turned out not to be true. So first lesson learned should have been for us as a continent or as a world, the whole world, to get the message.
Africa has the biggest resource as young people. In universities,
the kind of research that young people are carrying out, is this responding to the challenges that Africa has? So if we are going to take advantage of the young people that we have and the universities, and that's the very first resource, and then we are going to be able to actually come up with a solution. So asking the, how are you engaging different, so how are you engaging the different institutions that are working with young people, or how are you engaging the young people to actually find solutions to the challenges that we have?
And very often we see that there's a huge gap between the needs on the ground and the academics within the higher learning institutions. Last question over here. Thank you. Would you come forward, or can we have a mic here, ladies, as quickly as possible? Thank you. Yes, and the gentleman is running. Thank you so much.
Yeah, thank you very much. My question goes effectively to the... My name is Jose Nyamusore. I work for the Ministry of Health, Rwanda, in epidemic surveillance and the response. And my question goes with the theme of this session, the global security and protecting the people of Africa. While the panelist was talking about the preventive and at the grassroots community level, I was wondering if we are not left behind another key component. As you can see, we are dealing with this issue while we are really only health people. And I was wondering, where are vets and environmental? As we know, currently 75% of public health threats are zoonotic diseases that tackle humans. So that was my question is, thank you very much.
Thank you. Because of time, I'm coming back to the panel for comments to some of the questions and comments that have been made on the floor. And then we'll take a parting shot from each of you. But several issues raised. Where are the vets? Where are the other stakeholders? So we're saying we're engaging and we must engage multi-stakeholders. But we don't seem to be getting that quite right yet. Our engagement with academia. You know, how deep is that? How much are we doing? And it comes back to the question of research. Community health workers, they are the ones who will identify. They are the ones who will red flag. They are the ones who will do most of the work. Why are we not seeing more engagement? And I just want to commend Amrith, actually, because, for instance, with midwives, the amount of work that you are doing on the ground is really supporting communities. Why are we not doing more of that? How do we balance resources between all these competing health interests, which are very real and very stark? And perhaps, Minister, let me allow you to comment on some of these things. Have any of them struck you particularly?
Thank you. I will first start off by saying there should be no big outbreak again, because we can prevent most of them, or we can prevent an outbreak from becoming big, provided we put the right systems able to achieve development. I would also like to stress the issue of the community engagement and working with the communities. There are a lot of good experiences in our various countries from working with communities and community health workers. I'm sitting down here and I'm wondering whether we cannot put in, as a region, a community health academy, collect all these rich resources and see how we can support countries one another to be able to turn our disease curves down. Because it is simple. We heard about 4.7 million was spent to curtail Ebola. I do know one country spent 1.8 billion in Liberia. So I can safely say about 2 billion was spent to stop Ebola. The question I keep asking everybody is, could we have spent that money earlier and prevent, we are going to spend less and prevent deaths? That means we did stress effectiveness and efficiency. Often when we talk about effectiveness and efficiency, we refer to governments, but we all have to be effective and efficient. It means the government have to be effective and efficient, donors have to be effective and efficient, implementing partners have to be effective and efficient, the private sector have to be effective and efficient. We also did mention the government cannot do everything, and governments have to realize we cannot do everything. So we should involve other stakeholders. This issue of national sovereignty and spreading our wings across everything will not help us. we need to involve others in doing our work to be more efficient and be more effective. And of course, we should emphasize prevention, and then we should build whole systems and non-systems in a fragmented way. If we are building whole system, we are supporting the system as a whole and preparing for the future so that we do not have one outbreak and all the gains made on one side is eroded. Thank you.
Thank you so much, Donald. Please.
Thank you. Well, I'll start with the easy one. Where are the vets? I am a vet. And then I would like to commend to you, while we're on that track, there's a really interesting article in The Economist this week, which some of you might have seen, which is trying to do some mapping of where the next zoonoses will come from. Very short, very interesting, but very scary, and I think you definitely need the vets. Totally agree on the primary healthcare workers, community level. I think what we just learned from Ebola is it's not just the primary healthcare workers, it's trying to decentralize resources from headquarters and centers and often in the capitals to the front line where the real work needs to happen. So one of the key things we found actually was district level, and supporting district level medical officers and responses is as important and often the most underfunded. So I totally agree with that. And then just on vaccines, I agree, but I would say, and we go back to research, probably looking, if Ebola happened in West Africa again, and as we saw in the recent outbreak in DRC, but we didn't need to use it, the new vaccine is absolutely groundbreaking and transformative in responding. And that's why we now have, for example, a fund under the Gavi, the Global Alliance of Vaccines and Immunization, with WHO to be able to deploy that vaccines to countries that cannot afford it quickly to prevent this. And then just lastly, as the Minister said, I think leadership is key, leadership across all levels and all aspects. And not least for me in that context, and one of the reasons we're sitting here, is the leadership that is coming out we need to support and see more of AFRO, the WHO Africa End of Life, because actually having the capacity in Africa to do the research, to do the surveillance, to support the countries is far more important than shipping it in from other continents, other parts of the world.
Absolutely. As I come to the other panelists, there was also the question of miscommunication. And the panic that it created during the Ebola crisis. You can also speak to that, Ben, please.
Thank you. Maybe I will take that first about risk communication. I think the fundamental issue here is about understanding communities. You see, before we communicate this risk and public health risk, we need to have an understanding of the communities, which I think was something that was maybe critically missing at the initial point of our response in Ebola. So understanding of the community. I mean, Africa may seem homogeneous in terms of racial characterization, but the reality is that our culture and practices are heterogeneous. So there needs to be a contextualization of whatever is going to be our communication package during responses. So that's my response to that question on communication. Then taking on the insurance, the Africa risk capacity. I think it's a very good initiative. It's something that at least we at the IFRC we have been engaged in. But I also think we need to move that a little further to ensure that while using this mechanism to prepare for future disasters, we equally ensure that we are building the capacity of local institutions and communities to be resilient. In other words, we need to ensure that these people are able to withstand the shock when it happens. So that is on the risk capacity. And I just want to also answer on the issue of community health workers, which I think is very crucial for universal health coverage, if we really want to achieve that. Is that the minister mentioned in the heart of Ebola crisis where community care centers had to be established. I think we've had a lot of rhetorics around tax shifting. I think it is now time that we do concrete things to put that into action. We have like 1.8 million volunteers, as I mentioned. These volunteers could be used at community level to do certain kind of tasks that could take away the burden from health facilities.
Thank you. Thank you so much for that. Dr. John, please.
So, for the interest of time, let me touch on three topics that came from the floor. One is the vet piece, which was addressed, but I think there's a whole dialogue and discussion on moving the One Health program forward, which is bringing the animal and the human health together and discussing and developing strategies that would help bring the resources. The key thing there is to make sure that the networks communicate. Okay, we are still, when we have the vets and the human side, I mean, people federate in their own constituencies. You really like to see people crossing the aisles and the vet networks talking to the human side. For the community health care program, I can't agree more. I think we are all on the same page. But I just want to put in a caution here that we should maybe step back and just formulate the question rather differently and say, what is the human resource for public health agenda that we need for Africa, including community health care workers. Right. That way we do not shift the pendulum to community health care programs and then we suffer the consequences of that inadvertent effects there. So it's a word of caution just to throw in there. For vaccines, probably I should take it a little bit further and caution and be a little bit provocative and say we need to invest not just for research in vaccines, but actually push the agenda and talk of an African strategy for manufacturing of vaccines, drugs, and diagnostics. I'll give you one example and I'll end there. I was in Egypt recently, and the president of Egypt is very keen to eliminate hepatitis C. And because the private company, the Prime Pharma, is producing drugs now at the rate of about $100 per treatment, he wants to screen everyone and put the positives on treatment. But there are no diagnostics enough to cover that. So I think we have to begin to take have a courageous discussion and say to meet universal health coverage, we also have to...
We must achieve this.
We must achieve it, and but we have to put in our resources into manufacturing.
Thank you very much for that. Dr. Rebecca, please.
Thank you for that. I also wanted to address where are the animal health and veterinarians, because in countries they're there, and there are much more strong relationships developed after avian flu, and that's been going forward. But I think in the 30 countries that the U.S. government is working with, all of them have strong programs in country to collaborate and to strengthen the surveillance between the human and animal health. In the incident management systems, animal health is right at the table with human health in events that occur. So we're seeing it in countries, Ethiopia, just to mention one, Kenya, and I mentioned Cameroon, as 3 examples where we're definitely seeing this. The issue of also engaging the community in the surveillance, and this is something we've been working with countries on in Burkina Faso, to name one, and Tanzania, but being able to detect, as one of the colleagues mentioned in his comments, the opportunity to have event-based surveillance, rumors that are being heard, or events that could then be reported to a frontline health worker. And this has actually detected different outbreaks of diphtheria, for example, that would not have been detected had it not been information coming from the community. So that's a very important role. And then my last comment was the question about where are the youth in this. And within the Global Health Security Agenda, there is a one group that is working, engaging the young public health professionals, engaging the youth in multi-sectoral approaches, but for advocacy for ensuring that countries see health security as national security.
Thank you for that. Dr. Emmanuel, you have the final word.
One word. Thank you very much. It is fair to say for the last 10 years, Rwanda has achieved significant progress in health sector, and largely not because they have a lot of resources, because they have all the way been innovating. And if we could think out of the box, perhaps, because people in this room know what to do. They know what to do. If we could think out of the box, like the examples I mentioned earlier, a testimony to what has been achieved in this country, we would, in my opinion, whether you're looking at resources to fund projects or programs, there are many ways of, finding how to go about it. In terms of capacity building, which I think is very critical. There are many ways of innovating. So I am insisting on what should be different from what has been done before. Since we seem to agree on everything else, structure, processes, I find no disagreement here. Whether you're looking at a community, you're looking at the regulation, whether it is international, it's regional, or in the country. What is missing, in my opinion, is we need to find our own solutions that suit our own perspective. People sit together and agree. The examples are so many, I could not structure them very well, but innovation, and you'll be able to cut across all sectors. As I said from the beginning, health cuts across all sectors. We've witnessed it in this country. So innovation, getting out of the conventional areas, and which is very difficult at times for people who are used to conventions. Thank you very much.
Thank you so much for that. Please, ladies and gentlemen, can we give a warm round to the panel for what is a difficult discussion? The truth is, we can't afford not to do it. And we've been told we actually do know what to do. And when Ebola hit and when crisis hit, communities, governments, and partners do stand up and do what needs to be done. But why must we let it get to that level? And so some of the key things that have been mentioned here: partnerships, multi-stakeholder engagement, community action, absolutely critical. Community health workers, we must invest in that. Been told about innovation, thinking out of the box and finding the things that in our environments will work. I love African proverbs and words of wisdom. I'm going to end with 3. The first one goes, even the best cooking pot will not produce food. It won't. Who are the stakeholders? What are their roles? Let's get all those things right and line them up. The second one is, if you run after 2 hares, you will catch neither. So what is our focus? And can we, as Africa, as African Union Commission, as the regional economic blocs, as nations, can we all move in the same direction? And the final one, a chattering bird builds no nest. Can we not talk for the sake of talking? And can we get into emergency mode and imagine, what if it was us today? Can we afford it to be us today? Let's do the work. We know what to do. Thank you so much for joining this session. Thank you.
Thank you very much, Julie, for your words of wisdom. I have a few announcements. We will have a 30-minute break, 30-minute health break, and please note that there are beverages and light snacks to be served in the foyer. Also be informed that we have a travel desk, which is